with autogenous corticocancellous bone from the chin. No, don't worry, don't worry. Now, block graft harvested from the mandibular symphysis have been very successful in the management of patients with serious alveolar defect prior to placement of dental implants. Now, one of the things you want to appreciate in implantology is that any area that you're going to do surgery on, you need to appreciate the applied surgical anatomy of the area. And if you don't understand the applied anatomy of the area, your surgery is going to be longer, you're going to be posed with a lot of problems, you're going to end up with complications. So that with regards to chin grafting, the region of concern is the bony corticocancellous area apical to all the lower anteriors and the lower canine, and possibly the first premolar on both sides, with the preservation of the continuity of the lower border of the mandible. Now, everybody believes that if you are taking a block graft from the chin or anywhere, the block graft has to be rectangular. But you are wrong. It could be rectangular, it could be circular, it could be triangular, as long as it conforms to the shape of the defect that you want to reconstruct. Now, that is a well-located rectangular block. It is between the mental foramen on both sides. And even this canine, even if it is as long as this, your block is far away from it. So this block is a safe block. And this is how you want to harvest a chin block graft. This is a deliberate illustration on a skull. And you can see this big block graft. Basically, the lower border of this block could have been about here, and the upper border could have been about here. So that you can see that in this situation here, the apices of all the lower anterior teeth and canine will be involved. And you will end up having to do root canal for all those teeth. You don't want that. Now, let us look at the success rate of chin graft. A high success rate in partially edentulous patients treated with chin graft and secondary implant placement has been documented. Mandibular symphysis as a donor site in pre-prosthetic reconstruction of atrophic edentulous patient has always been used in implantology. And in fact, in those days, those are the main procedures. Block graft from the chin, block graft from the chin. And in those days, there were very little bone substitutes. Clinical studies on the comparison of chin graft with iliac crest or rib graft in reconstruction of alveolar cleft reveals only minimal complication at the mandibular donor site and significantly less resorption associated with chin graft. And I'm going to ask Dr. Chukwu, why is this? And most likely you wouldn't be able to tell me. And of course, questions will be after each lecture or at the end of the session. Now, experimental evidence also suggests that intramembranous bone grafts such as chin graft maintains more volume and show less resorption than endochondral graft. And of course, one of the problems with graft is that a bone graft does not take in the same way as heart graft or skin graft or liver transplant takes. This is most likely the result of rapid vascularization, that is the answer, of intramembranous bone graft. You see, bone graft that are taken from bone that form as a result of intramembranous ossification do have rapid revascularization. The possibility of a better potential graft, incorporation of embryologically similar donor and recipient site requires future research. Now, the surgical technique. You have to give profound anesthesia with bilateral block using lidocaine containing adrenaline, and you have to inject both the donor site and the recipient site. And usually I inject the recipient site first because that is the site I'm going to operate on first. And the reason for that is very obvious, because you want to go see the shape of the defect, measure the size of the defect before you now go to the donor site. A supraperiosteal incision on the palatal aspect of the ridge is made with subsequent mucosal flap elevation and incision of the periosteum on top of the crest. The recipient graft bed is prepared by removing any fibrous tissue or foreign body material from previous endodontic treatment, for example. And then, with regards to the donor site, you do the same thing. The bone graft are readily obtained from the apices of the mandibular, incisor, and canine via intraoral approach. What you do is an incision is made in the alveolar mucosa beyond the mucogingival junction between the premolar region. Now, after the symphysis has been exposed and the mental foramen is located, a rectangular outline is made using a surgical bore. Of course, it doesn't have to be a rectangular outline, as long as it is corresponding to the shape and the size of the defect in the recipient site. Not consistent, huh? I think I need to get close to this. Yeah. The superior aspect of the rectangle should be at least 5 millimeters below the apices of the teeth, and the integrity of the lower border of the mandible must be maintained. The depth of the osteotomy depends upon the insufficient width of the maxillary alveolus. Osteotomy is then used to free the block, and then you can harvest more cancellous bone in the donor site. Now, it's always good to have good manners in bone grafting. You're taking bone from the chin, you're taking nice bone from the chin, gold standard bone, autogenous bone. So what you want to do is you want a mixture of demineralized freeze-dry bone and some calcium phosphate to now put back in the chin. Okay? So that bone can form quickly there, and patients are willing to accept that kind of treatment rather than you say to them, don't worry, it's going to grow back on its own, and so on and so forth. So you now go, graft the recipient site, suture, take post-operative radiograph to assess bone repair as time goes on. And in fact, one of the things that you can do, which is very, very important for medical legal purpose, is, before you commence, you do vitality test. And after you finish, the following day, you bring the patient in and do vitality test and record. Okay? You see, because out there could be very unfriendly. Out there could be very unfriendly. And before people find out that somebody who is trying to be unkind to you is really unkind to you, you may have spent money on law, this, legal, this and that, and then embarrass yourself and your practice and so on and so forth. All it takes is for your patient to be a little bit pissed off with you, go to another person and say, oh, I'm having some abnormal sensation here and there and there. And the person say, oh, he damaged your nerve. He damaged the tooth. And it may not be so. All right? Abnormal sensation after surgery, a lot of them, do not necessarily need be as a result of primary damage to any structure or nerve. I'm going to teach you nasal septum graft, which we did during the cadaver session. We did that during the cadaver. Yeah. Now, the only indication for nasal septum bone graft is when you have cortical bone dehiscence in relation to placement of implant in the anterior teeth. And the reason is because you're placing implant in this region and you have raised the flap in that region. So if you need bone graft, you can extend. You see, your flap is probably normally up to this level. So you can extend the flap intraorally so that you can have access to this nasal bone. And all you need to do is to use a bone ronger, a bone forceps, bone nibbler, to nibble a nice chunk of this bone, which will come out flat, and you now paste it over the dehiscence. It is optional for you to add any other bone graft and put membrane. If you are wealthy with bone graft and so on and so forth, please go ahead and do that. Now, let us look at iliac crest grafting. The indication I told you earlier on today, when you need a large chunk of bone. And let me explain to you. This is the most severe situation where you have atrophic mandible. Dr. Mama, if you referred this patient to me to put bone graft for you, you have lost the patient. As much as I like you and I want you to earn money from your patient, I cannot help you because I'm going to take that patient into my office, put a bone graft there, and put in all the implants there because the implants will be the stabilization for my bone graft. And I'll say thank you. Maybe at Christmas I send you a big bottle of wine and so on and so forth. At least we're friends. And then, say to you, don't worry, your patient will be coming back to you for restoration. But remember, the patient will have loved my treatment, my fingers, the way I talk, the way the patient will say, Dr. Gonzalo, I just want to finish everything with you. I mean, Dr. Mama is a nice dentist, but you did the surgery. I want you to finish for me. So you have lost the case. And maybe this patient will have brought you about 10 more cases in the next 5 years. So you have lost all those cases also. So they'll become a case. And that is why you have to understand how to do this thing. And let me teach you how to do it. Although, because you are not a medical doctor, you cannot do it on your own. So you will have to liaise with an orthopedic surgeon or a general surgeon who will come to the operating theater with you. You will give that surgeon a special tray. You will have taken the impression of the patient's mandible. Give the surgeon a special tray in the operating theater, and they will take exactly the U-shaped bone graft that you need. And then they'll give it to you in a nice dish. They'll close and they'll say bye. I mean, if you're fast, before they leave, you've already placed the implant on the jaw and screw in 2 implants, starting from the anterior and then right, left, depending on how many implants you want to place there. Okay? Now, in that case, and most insurance will probably pay for the assistant surgeon for taking the bone graft and so on and so forth. And that is a larger view. That's a more precise view, and you can see what is happening there. So that there is no way that you can escape not understanding iliac crest bone graft. And that takes us to the fact that you have to understand also how you liaise with the operating theater and the surgical team, and we will talk about these as a roundtable discussion tomorrow. Now, what I want to share with you further today is the various surgical protocol. I'm going to do endopause surgical protocol and then this scan there. 5, right? Now, we're not going to go so much into detail, and this is going to take us just about 2-3 minutes, because I've referred you to the CDs during the course. Now, the step 1 is the use of the round ball. And let me tell you, the endopore implant, whether you like it or not, is one of the BMWs and the Mercedes-Benz implant in the world. And that is the implant that is going to make your practice. And Dr. Zoh, sitting here, will tell you that is the implant he loves. Am I right, Dr. Zoh? Yes. And he will tell you he has never damaged any nerve in 7 years. He has never gotten into any serious complication in 7 years. And he has never have to abandon any implant case in 7 years. Endopore implant. I highly recommend it to you, and I'll talk to you about it. Okay? So, basically, that is a round ball. And you use the round ball to penetrate the cortical bone at a speed of about 1,500 to 2,000 RPM. And after that, you will use the pilot drill, which has a 5 millimeter marking, 7 millimeter marking, 9 millimeter marking, and 12 millimeter marking. And the speed for the pilot drill is 1,000 to 1,500 RPM. So you will drill with the pilot drill to the length of the implant that you propose to place in. So if you are going to place in a 12 millimeter implant, you drill up to the point where the 12 millimeter marking disappears. And then, of course, it is very important to see the inclination of your proposed implant in the bone. So you place a paralleling pin into the osteotomy site. Subsequently and finally, you will take the final finishing drill to now drill precisely to the size of the implant that you want to place. Dr. Mama and Dr. Maxand, watch this. Let's say the implant you want to place is 12 millimeter long by 4.1 millimeter in diameter. So this is the finishing drill. And as you drill with that, you are ready to put in your trial implant. And once you place in your trial implant and it sits snugly, it is time to now place in your implant. This drilling sequence takes exactly 5 minutes and your implant is in. And, I'm going to teach you how to be smart from the beginning. If I am doing the whole mandible, right? So the first thing I want to do is to ascertain if I can use the same diameter implant and length implant for the entire thing. So I just go round ball, 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 round ball. Pilot drill, pilot, 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 pilot. Finishing, 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 finishing. Implant, 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 implant. And you tell the patient, I'm done. And they're like, you know what I'm talking about. Now, the trick, though, is that it is always nice. You see, I usually don't place mine flushing like that to the alveolar crest. I usually place it about 1 millimeter below the alveolar crest. I call it super sinking, and I think it is wise. And of course, it's always nice for you to tap the implant with a tap just to make sure it's seated well, and then test the cover screw and make sure that your cover screw can come out when you want it. So that when you are doing your second stage surgery and you're having difficulty in unscrewing the cover screw, you check your notes and you see that you have documented there that the cover screw can be removed. Then you know that there is no defect, so that you know that it is bone, more bone that you need to remove so as to be able to remove your cover screw. You close, and so why would the protocol be different from that for a threaded implant? You see, I'm going to show you again Go back to, so you go to scan, right? Now, threaded implant, round bore, next. Pilot drill, next. And then that is just to prepare your alveolar crest as a countersink, and then a wider drill, and then your implant placement. But most threaded implants are not as precise as this. Huh? And of course, with this system, you have a mount which you connect to the handpiece to now mount your implant, to now place the implant in the osteotomy site. And then the removal of the mount, and then the final placement of the implant and closure. The afternoon session, I'm going to be teaching you about BioGuide resorbable membrane. However, I've now started using a lot of cytoplast, and basically they are the same, and a lot of things that I will say about BioGuide applies to cytoplast. And except for the fact that the BioGuide is a membrane from porcine, and cytoplast is from what, Dr. Cytoplast? I need you to listen attentively to this. Now, resorbable membrane are divided into two, basically. Those that are of synthetic polymer origin, and those that are of natural biomaterials, such as collagen. The synthetic polymer include the lactide and the glycolactide copolymer, and the polylactic acid blended with citric acid esters. Of course, the natural biomaterials is the collagen, which could be from the horse, collagen from the cow, collagen from the pig, and so on and so forth, and collagen from fish. Now, let us look at the historic background. Gore-Tex membrane were previously used. They are now resorbable, although they have been shown to be successful in osseous defect. There has been no drawback with their use, but now, today, we are beginning to use more resorbable membranes for obvious reasons. One of the problems with the non-resorbable is the premature membrane rupture with possibility of infection, and then the need for second surgical procedure to remove the membrane. And believe it, I think it is unwise to use a non-resorbable today when you now have resorbable membranes. Because there is no doubt in my mind that when you go and remove the membrane in 2 weeks' time or 3 weeks' time, you're going to be disturbing bone regeneration. The development of biomaterial and the development of bioresorbable membrane, which will permit a single-site surgery while still providing an effective barrier for regenerative procedure, has been the recent breakthrough. The collagen is extracted from veterinary certified pigs, or it could be veterinary certified cow, and carefully purified to avoid antigenic reaction. It is sterilized in double blisters by irradiation. The recognition of safe and effective use of collagen has led to the development of BioGuide, which is a slowly resorbing bilayer collagen membrane which maintains an effective barrier function for the prolonged period of time that most experts agree to be required for successful GTR. Now, I like to do this. I like to teach you a little biochemistry. This is the structure of collagen. And that's the collagen fiber. The collagen fiber is made up of collagen fibrils. And you can see the collagen fibrils there. And the collagen fibrils consist of microfibrils. And the collagen microfibrils consist of collagen molecule. Collagen is one of the most thoroughly researched biomaterial. It is a fiber protein which contains hydroxyproline and has a structure of triple helix, just like the DNA structure. The helix consists of single fibers bound together, resulting in a great tensile strength. Collagen fibers are responsible for the elasticity of crystalline structures. For many years, collagen has been used in surgery, for suturing, and for covering wounds as an hemostatic agent. Let us look at the advantages of BioGuide. It maintains a barrier function for at least 4 months, and as such, improves guided tissue regeneration. It slowly resolves and eliminates the need for second surgery. Its effectiveness compared to the non-resorbable barrier membrane needs to be considered. And then numerous indications for use and ability to customize membrane to allow the inventory reduction. And this was when Gore Resolute was the only competitor in the market. And Gore Resolute designed their membrane in such a way that there is a membrane that you use for canine, one for you use for premolar, one for molar, and so on and so forth. And you really don't know what your next GTR is going to be like. So that the regular standard rectangular size of Gore Resolute of BioGuide was of use compared to the Gore Resolute, because you can always cut to size and to shape. It is easy to handle and has excellent wound healing potential. A membrane suitable for regeneration technique should fulfill certain criteria. And one of these criteria is biocompatibility. It must be compatible to your biological system. It must have cell occlusivity. In other words, it must prevent undesired cells from coming into the area where you're trying to regenerate bone. It should integrate properly with the tissue. It should have no influence or only positive influence on wound healing. It should have suitable kinetic properties with regards to resorption. It must be malleable and manageable. BioGuide, as such, reproduces the physiological barrier function of the periosteum with a natural tissue material. And you can see the bilayer structure of BioGuide. You can see this is the smooth surface, and that is the rough surface. And the structure of the smooth surface on electron microscopy, structure of the rough surface on electron microscopy, resorption of collagen. You see, like I said to you, our patients are beginning to have access to a lot of health information. They will ask you, doctor, you are putting this thing in my body, and you're telling me that you don't have to remove it, it's going to resorb on its own. Where does it go? You know? So you need to say to them that, well, it has a resorption cycle. And the resorption is basically the resorption of lactide and glycolactide copolymer through the formation of glycolic and lactic acid in the Krebs cycle. And we all know the Krebs cycle, which is the tricyclic acid cycle, that cycle that we learned initially in biochemistry when we entered medical and dental school, the TCA cycle. So that is the resorption kinetics for the BioGuide. Your patients will ask you, doctor, you know, how do you know I'm not going to be allergic to this thing that you are putting in me? So you will say to them that the collagen is weakly immunogenic. More so because the processing of this collagen has actually removed the immunogenic component of the collagen, which is a telopeptide. So that during the processing of collagen, the telopeptide aspect of the chain is split off. So that this is what you have. And it is the telopeptide section of this unit that is immunogenic. So that what is remaining is weakly immunogenic. So I will repeat, the location in the molecule which is of great importance for the antigenicity of collagen are the so-called telopeptide region. During production of BioGuide, the terminal telopeptide are split off. Specific purification process ensures that fat and protein residues are completely removed. Let us review the indication for use of BioGuide for guided bone regeneration. And today I want you to appreciate that guided bone regeneration is the same thing as guided tissue regeneration because bone is a tissue. So you can use it interchangeably. For simultaneous use of guided bone regeneration and implant, for augmentation around implant, especially in immediate implant socket, and you will understand before the end of this course that I do not do immediate implant without doing bone grafting. Even if you have to just sprinkle a little bone around and cover with membrane, that is the way to do it. And you will understand very soon in the experimental seminar section of the course why this is so. Alveolar bone reconstruction for prosthetic treatment and filling of bone defect after root resection and also cystectomy. And let me tell you today that I used to extract a lot of teeth. I used to enjoy it. I used to do them very fast. But today, my extraction has become very slow. The reason is I try to remove my teeth without removing a speck of bone. It takes time. And it is because I understand what bone is. I have respect for bone. You know? for augmentation around immediate implant after tooth extraction, and for ridge augmentation. So basically, this is my introduction to you with regards to BioGuide. I have attachments to BioGuide in that BioGuide was the first membrane that I used. BioGuide was the membrane that I used for my animal experiment to validate the Ogunsalu sandwich technique. And BioGuide was actually the first membrane that I used for the Ogunsalu sandwich technique. However, you know, I've been using the cytoplast over the last 4 or 5 years also. I found it very useful, and I think you need to try it. It's cheaper than the BioGuide. It does the same thing, and whenever you call the company and you say you are Ogunsalu's guy, they'll give you plenty discount. Okay? Now, what we're going to do next is we're going to do management of drug reaction. Now, you see, in everything you do, you must try to be thorough. And one of the things I want to teach you today is, yes, you're sinking implants, you're going to use antibiotics, you're going to use this, you're going to use that, you're going to use local anesthetic agent. Supposing your patient reacts to any of this, what would you do? Drug reaction may occur following the use of antibiotics, local anesthetic agents, or analgesics. All the categories of medication that I mentioned are usually utilized in implantology, and as such, the clinician placing implant may well find himself or herself having to treat anaphylactic reaction or progressive anaphylactoid reaction during the course of a patient management. The question is, are you prepared to manage this patient? Anaphylactoid reaction is a hypersensitivity reaction occurring after the administration of an anaphylactogen. An anaphylactogen is what you introduce that is going to cause the reaction. So the medication are anaphylactogens. Anaphylaxis and anaphylactoid reaction have similar pathogenesis, and many clinicians fail to understand the difference between anaphylaxis and anaphylactoid reaction. Anaphylaxis occurs like that, boom. Like you inject penicillin into a patient just goes. But anaphylactoid reaction is progressive, and it takes some time to build up. Although the pathomechanism is the same, one is faster than the other, and one requires more emergency and aggressive management than the other. And that is the difference. The reaction is typically a type 1 hypersensitivity reaction mediated by Ig antibodies capable of releasing biologically active factors such as histamine, vasoactive amine, slow-releasing substance of anaphylaxis, and eosinophil chemotaxic factor, including basophil kallikrein. All dental practitioners should be aware of the diagnosis and with management of emergencies such as anaphylactoid reaction and anaphylaxis. Resuscitative drugs such as antihistamine, adrenaline, and corticosteroid should be available at the chair side for immediate use. And believe it, in my early days, I came across a case. In fact, to let you appreciate how lucky I was as a dental student, after giving local anesthetic agent at the University of Ibadan, where I trained as an undergraduate, and my bosses were there when I gave the anesthesia, a patient went into take reaction. And, I was very shocked. I mean, I really didn't know what to do. I was a student, but they managed the patient for me. And then, again, in my early practicing years, 2-3 years after graduation, I had another case. And this case, I managed by myself. Coincidentally, a month earlier, I had read Medicine Digest magazine, which came from Australia, Australia edition. And there was management of anaphylactoid reaction there. And I quickly was able to manage my patient. And today, that happened to be the first paper I got published in my life. The early symptoms of anaphylaxis include sensation of warmth, itching particularly in the groin and axilla, feeling of anxiety and panic, and all these were the things the patient told me. Progressive or progression may occur leading to erythematous rash, which she had, urticarial rash, edema of the face and neck, and laryngeal edema. And then when it gets severe, the patient can start wheezing. A patient that doesn't have asthma or any chest problem begins to wheeze, and there is dyspnea, there is hypertension, arrhythmia, and cardiac arrest and death if patient is untreated. And as such, I'm going to refer you to the manuscript of Ogunsalu in the Australian Dental Journal, which was published in 1998. I'm sorry, it's my second paper. All right? And in fact, for you to understand what it is to publish a paper in the Australian Dental Journal, it really has to be a good paper. I actually published about 5 papers in all in the Australian Dental Journal. Now, we are going to look into the criteria for success. Now, sometimes I say to myself, this is neither here nor there. And Dr. Amin will probably appreciate that to some extent. The most important thing in implant placement is the selection of your patient. And you do not want to select a case that, yes, it's going to pay you good money, but then it's going to fail, and so on and so forth. You want to select a case that you know that will be successful by all the presenting situation, both clinical, radiological, social, psychological, and so on and so forth. And once your implant has been placed in a solid foundation, and that is why I taught you about bone today, because that is what you need for a solid foundation. The next most important thing is clinical and radiographic examination, which should be regular, continuing, and consistent. And it is during these review visits and investigation that you will come across factors that may lead to failure, which can be corrected prior to restoration, or even factors that may lead to failure after loading the implant. And during your loading of the implant, you really need to be observant. And if there is any evidence of peri-implantitis, Don't fool yourself. Go for it. Curettage, enucleation of granulation tissue, bone grafting, and so on. And I found myself on a few occasions loading my implant and having at the same time to treat peri-implantitis on a newly loaded implant, because I've seen pockets there and I don't want it to persist. And this is one of the reasons why when I am loading an implant, I mandatorily give the patient local anesthesia. All right? Now, individual unattached implant should be mobile, should be immobile. There must be no peri-implant radiolucency present. And the vertical bone loss must be less than 0.2 millimeter annually. 0.2 millimeter annually. And there must be absence of signs and symptoms such as pain, infection, neuropathies, paresthesia, and violation of mandibular canal. High success rates have been recorded for implants in the edentulous anterior jaw. MCQ question. But most likely, if you are not vigilant, you're going to miss it. You say, Max, my MCQ questions are very tricky, huh? Although I'm going to give you tips right here and tell you which slides, but I'm still going to confuse you. And I get a lot of pleasure from doing that. I don't know why. Now, appropriate instruction on oral hygiene should be given to the patient during the treatment and must be reinforced at follow-up visits and regular reviews. Assessment at review appointment must include plaque and calculus deposit review, clinical assessment of mucosa for bleeding and for pockets, including measurement of this pocket depth. You must check for mobility, and you must do your radiology. Take a radiograph and compare it with what you had before. Now, you must always inspect the superstructure. Marked occlusal wear of the facets can be an indication of failure to come. Crack or fracture indicating inexactness of fits. And really, I remember I had a patient some years ago, and because she flew down to get her restoration, but her restoration did not come on time because I used a lab abroad. And it was only when she left that the restoration came. So I told her, I said, don't worry. You live in New Jersey. My friend, who is a guru of implantology in the US, also lives and practices in the area where you are. So I'm going to I'll send the job to him, and he will fit in the restoration for you. And that was Dr. Kenneth Judy, the ICOI co-chairman. And shortly after I sent the job to him, he called me and he said to me, Chris, I can see a crack on the crown, so I don't want to put it in the patient's mouth. And you know, when you look at these people who have been doing implants years ago, they have a wealth of experience, and you have to listen to them, and you have to follow their instructions. First of all, when you see a big businessman, maybe one of the things you want to find out is what he has in his portfolio. And what I'm saying is that, you know, Innova Ultratronic used to be Innova. It is now Cybron. And from when it was Innova, they have had porous surface implant, the internal connection type. Dr. Mama, Dr. Maxan, and Dr. Chukwu. You see, you have the internal connection implant, you have the internal and external hex, which you can use as two-stage procedure. And the internal connection is for one stage. All right? The restoration for the internal connection may seem to be straightforward, but a little bit tricky, because more components. The restoration for internal connection is the best and the easiest. It's just connecting an abutment and you go ahead and restore. The same thing with external hex, but sometimes there may be problems in fitting the abutment properly into the external hex section, and you may have screw back out. So that with the porous surface implants, they have the internal connection, the internal hex, and the external hex. They also have the threaded implants, which is also internal hex and external hex, and they don't have internal connection. Okay? The company then decided to manufacture the porous surface implant combined with the threaded implant. In other words, the coronal part was now made threaded, and the apical two-third was made to be beaded. Okay? And believe it, I'm a scientist. And you see, you can't sell me anything because you want to sell me. I never bought the hybrid implant from the company. I never sold it. I never taught it. And you know why? Because I knew it was not going to work. Because you could not design an implant like that. Maybe it would have worked if it was apical one-third screw and the remaining coronal part beaded. And within 2-3 years, the failure rate was recorded very high. And today they have stopped the manufacturing of the hybrid type. Why I am telling you this is that this is a very honest company. Do you understand me? They manufacture something and they see that it's not working and they removed it from the market. A lot of implant companies today have obviously seen some faults and big faults in their implant system, but they are still manufacturing it because of money. So that this alone is a testimony that this company has the interest of the patient and the clinician. They sell surgical motors and they sell regenerative products like membrane and bone grafting material. And they sell bone spreading and condensing system. And for years, I've taught these products, and it has never created any problem for the users. And for you beginners, my recommendation is that you invest in this system. Endopore especially. And if you're on my course, which you are, they give you the surgical kit free for all these 3 systems. They give you the osteotome kit free. They give you a lot of things free, prosthetic kit free, as long as you buy a few implants. And you will talk to the rep tomorrow. I mean, I'm not sure if she's flying down, but if she can't fly down, I've told her, you know, she can be allowed to speak to you. All right? Now, let us look at the evolution of the beaded implant. You see, it evolved from porous surface hip implants, which has been used since 1970. Something that was developed by bioengineers such as Dr. Pillai. And this is the history. It was developed at the University of Toronto in 1983 by Professor Watson, DePorter, and Pillai. And check this out. Professor of Prosthodontics, Professor of Periodontics, and Professor of Biomaterials. And a lot of the implant systems that are developed today, people just form a company and they start machining an implant. It never went through a scientific review or panel like this. And this is the history of Innova from 1988 to 1999. And of course, from 1999, a lot has happened up to today, including the fact that they have now added new implant systems such as the Pit Easy implant system. And I'll tell you again, I enjoy placing the Pit Easy, and I will introduce you to it. In fact, when you sink in the Pit Easy implant, the only thing you want to do next is load it immediately. It tells you, load me now. But you see, I pause, and I don't want my patients to abuse what I'm doing. So I just give them a little time, and then I load, you know. So, let's go on. The design rationale: reliable implant fixation by bone ingrowth into porous surface region, which is formed by a sintering process. And the surface area provided by a 7mm long beaded implant is more than the surface area provided by a 13-14mm long implant, because each of the beads contributes a large amount to the surface area. So that with regards to beaded implant as compared to screwed implant, with the beaded implant you have a wider surface area for osseointegration. Now, it is very important for you to appreciate the fact that the structure of the endopore implant is tapered, truncated, cone shape. It is porous surface. You have the internal hex, you have the external hex. And again, like I made mention, you have the external internal connection design. Now, with regards to the internal hex, you have the 4.1mm diameter and the 5mm diameter. And the smooth surface, this is the smooth surface of the implant, the smooth coronal surface. And this smooth coronal surface need not be in bone. It is this beaded surface that needs to be in bone. But from my experience, I enjoy sinking this into bone, because it compensates for the annual bone loss that you will eventually have. And you can see that this implant comes in 7, 9, and 12mm length. And the external hex comes in the same diameter as above, but additionally as a 3.5mm diameter. And as such, you can use this in areas with which are narrower in width. And they come as 1 or 2 millimeter smooth coronal region, and they come as 5, 7, 9, and 12 millimeter in length. The 5 millimeter in length implant are best utilized in the subantral region, which will avoid you doing unnecessary maxillary sinus lift. And believe me, it works very well. And then the internal connection comes as 5, 7, 9, and 12 millimeter length, and comes in 2 diameter, the 4.1 and 5 millimeter diameter, and the 4.8 abutment platform diameter, to use the same prosthetic component. And this is nice. Okay? And then you have the transgingival collar of 1.8 millimeter or 2.8 millimeter, and the remainder of the implant is the porous surface. There is superior osseointegration with primary stability, and this is the unique property of the beaded implant. The innovative implant system of the hybrid combine the superior biomechanical feature of porous surface implant with features of the traditional threaded design. The hybrid design allows the use of shorter implant while initial stability is the criteria. But you see, why I read this to you is that a company that described an implant like this, they thought so highly of it, but they had to withdraw it because of credibility. You know, it's like bringing out a vehicle which you claim is better than BMW or Benz, and then you now say to people, I'm sorry, I'm not manufacturing. A company like that, any other product they have, just go for it, because they have recorded very high success rates. Now, the necessary requirement for bone ingrowth includes biocompatible material, limited relative movement of the implant tissue interface during healing, and then the sphere size must be about 50 to 150 micrometer, and the pore size must be about 50 micrometers. And then the titanium alloy has the following feature of high fatigue strength, excellent corrosion resistance, biocompatible, in that, you know, extensive use in load-bearing dental and orthopedic implant has led to continued success. And this is the sintering process, and I will refer you to the CD that you will get from the company tomorrow when your FedEx package comes in. The company sponsors this course, supplies all the material that are being used, and they want you to be taught properly. Now, this is a company that is really not interested in you using their product if you are not appropriately trained. Do you understand what that company is saying? Huh? That company is saying that, hey, we need 100% success. And that is why they strive for it. And these are all the characteristics of sintered titanium A14V. A solid state diffusion process with consolidation of the titanium alloy powder to a bulk form with desired pore characteristics, sintered at 1000 250 centimeter, therefore no melting or liquid phase formation. Strong bonding results between the particle and particle to substrate, and then sinter neck diameter and sinter neck zone and bulk microstructure feature are all features. And the implant to bone interface has 3-dimensional mechanical interlock. You can see this is human histology. You can see bone implant interface. This is the beaded implant. And that is the bone implant interface. Now, again, the implants are coated variably. You have the machine surface, you have the titanium plasma sprayed, the acid etched for grit blistered, and the hydroxyapatite coated. And really, I read some implant journal in which people claim that it is the hydroxyapatite coating of implant that makes it more successful, especially in immediate implant. And again, I believe that the titanium plasma spray is a very good coating. And for years, I've always ordered titanium plasma sprayed implants. Okay? And these are the features of the machine surface and the plasma sprayed surface. These are the features. So you should go through them. The acid etched surface, these are the features which you need to go through. And the sintered porous surface, these are the features. And then the surface area estimate, threaded implant versus porous surface implant. And that is the surface area comparison. And you will appreciate that with regards to the threaded implant, look at what you're getting, to the beaded implant, for a 4.1 millimeter by 7, this is what you're getting. And for a 4.1 by 12, look at what you're getting. And for a 3.5 by 9, this is what you're getting, and so on and so forth. And, this is the stress distribution with regards to the threaded implant versus the beaded implant. And this is the estimate of available surface for, you're looking at the diameter, the length, and the geometric area of the truncated cone and the estimated available area. Endopore implant has the following benefits, and I'm going to stop this lecture on endopore at these benefits. It has 3-dimensional interlocking interface with bone. It increases surface area. It has uniform stress distribution, and as I showed in the diagram previously, predictable and minimal crestal bone loss, greater surgical option with shorter implant. You have internal, external connection, and extensive prosthetic option. And of course, you now have internal hex, and then shorter healing period. Now, this is the surgical kit. It is very simple. That's the round bore. And after the round bore, you use a pilot drill. After the pilot drill, you put in a paralleling pin. And then this is a drill, final drill for 7 by 4, final drill for 9 by 4, for 12 by 4, and so on and so forth. And then these are the trial implants. And it takes no time. And I'm going to teach you how to be stylish and how to be very logical with the things you do. I always order 4.1 millimeter diameter. Okay? And I always order a lot of 9 millimeter long implants and some 7 millimeter long implants. All right? The reason why I order the same diameter is for simplicity in my restoration. When you order the same diameter, then you'll have the same abutment size. And then your technician, in fact, if I do a prescription and I send to my technician and I say the implant is 3.5 or the implant is 5, he's going to call me and say, Dr. Gonzalo, you sure? I'll say, yes. I just decided to use that on this patient. And Dr. Zor will say to you that sometimes I'll have to go personally to his office and beg him for a 3.5 endo-4 implant. And I don't, you know, I mean, that's why you need to have the right people around you, you know. I do order some, but because I do a lot, they disappear very quickly. And when I need and I'm short, I just go to Dr. Zor, you know. And he's a good friend. A good friend. And why I'm saying this to you is that for the benefit of your patients, don't be afraid to ask from your colleague. Huh? You know, sometimes I could actually put in a 4.1 there, but I know the best thing for the patient is a 3.5. I'll say, Doc, I'm going to return it, and of course I return it. And of course, he's free to come to you and ask you at another time. All right? So, you can come out of that. That brings us to the end of the lecture on the surgical component. And what I'm going to do is I'm going to teach you about the pharmacology of drugs used in anxiolytics. Now, this is a topic that sometimes when I am teaching it, it gets to a point that I'll say to you, listen, read up the remaining of the PowerPoint, because I don't have time for the remaining, although I did the PowerPoint presentation. And you will understand why very soon. In 1991, the American Dental Association presented figures detailing that 12 million Americans have dental phobia, while another estimated 12 to 14 million suffer from dental anxiety. The removal of dental anxiety for the purpose of meaningful dental procedure is called dental anxiolysis. So that, you know, I'm introducing you to a terminology which in your practice can be an income. So you're treating the patient for dental anxiolysis separate from placing implants. All right? About 30% of the population, that is 85 million people, need some form of anxiolysis or sedation to receive dental care. And only 60% of these do well with nitrous oxide sedation alone. This means that 34 million phobic patients are currently avoiding routine dental visits. A large percentage of them also require dental implant therapy. And again, I am introducing you to another terminology, DIT, dental implant therapy. You see, when your case note says dental implant therapy, what it means is that an ongoing treatment. It is different from when your case note says dental implant treatment. That means you're saying you're committing yourself, you're treating the patient, and nothing is going to happen and there's no need for follow-up and so on and so forth. So those are terminologies that you need to know. Now, what are the factors that affect dental anxiolysis? The education of the dentist. If you are not educated enough to know the various modalities to quench dental anxiolysis, then you cannot offer it. The state regulation and policies. For example, in the United Kingdom, GA procedure used to go on in dental surgeries, but has now been banned from the Post-Willows report in the 80s. And furthermore, they have gone as far as banning IV sedation unless there are certain criteria that are fulfilled, and the fact that an anesthetist and a nurse must be present. The cost of insurance is also a factor, and the level of competence of the dentist together with the equipment available to the dentist. Let us look at IV sedation. IV sedation, which is also called intravenous sedation, is seldom used in dental offices today because of insurance costs and the need for costly postdoctoral education, and also the regulations that emerges from time to time as to who can perform these procedures. The cost and scarcity of training program increases the problem. Typically, these courses require 60 hours of training, which will give you about different sedation techniques, and these courses may cost as much as $6,000 US. Actually, they've gone up. This is oral conscious sedation, and this can be accomplished with the following agents: diazepam, which is not reliable; alprazolam, which is the same thing as Xanax, reliable. You have temazepam, midazolam, which has to be used with caution, and also trazolam. Now, let me quickly tell you that for years I've been using Xanax. And I give the patient 1 milligram of Xanax, and they are cool. And, you know, even for wisdom teeth remover, 1 milligram of Xanax, and the patient is cool. I used to use this thing without actually reading any article on it. And I used to call it Xanaxification of the patient. And it was not until about 2003 that I saw an article in the American Journal of Oral and Maxillofacial Surgery about the use of Xanax as a standard sedative modality, oral Xanax. Of course, there is no IV or syrup. It comes as just tablets. Now, diazepam is in the family of the benzodiazepine. They should be used with caution in patients with respiratory disease and muscle weakness, such as myasthenia gravis. Patients with history of drug or alcohol abuse, and patients with marked personality disturbance, or patients who are pregnant or are breastfeeding, including patients with hepatitis disease and other conditions which you can read in the literature with the medication. Contraindication. They are contraindicated in respiratory depression. They are contraindicated in patients with acute pulmonary insufficiency. And they are contraindicated in patients with severe hepatic impairment, an obsessional state, and also patients with chronic psychosis. These are all the side effects of diazepam. Drowsiness, lightheadedness, confusion, ataxia, amnesia, dependence, increased salivation, GIT disturbance, changes in libido, and restlessness. And basically, because all these other ones that I'm going to be talking about belong to the same family of benzodiazepine, they will have the same kind of side effects and so on and so forth. And diazepam could be administered as oral, IM, and IV. All right? It has a longer state of sedation. Or maybe I should rephrase my statement that if you want a longer state of sedation, you can achieve this by use of alprazolam, or lorazepam, or temazepam, or midazolam. Now, the caution, the contraindication, and side effects are the same as for diazepam. Now, what I want to state here for you is that you really have to know how to use Xanax. It is important for you to take the history and make sure that the patient has never used Xanax before. If the patient has used Xanax before, it's not going to act well for your procedure. And if you're going to use Xanax for a patient today for the first time, you may as well use that opportunity to do a lot of the treatment that needs to be done. Okay? What we do is we prompt the patient. Now we're going to give them Xanax, tell them about the medication, tell them it is oral tablet, tell them it is bitter. It is very bitter, so you have to swallow it very quickly with water. If it touches your tongue, it's very bitter. And when they come into the office, you give it to them immediately. And you wait for about 30 minutes to 45 minutes, and then take them to the chair, let them lay down there. They begin to feel tired. They begin to feel uninterested with what you want to do. So a previously anxious patient who is afraid of what is ahead, which is surgery or dental treatment, is no longer worried. And then you give your local anesthetic agent in 45 minutes. Of course, with your local anesthetic agent, they may groan and, right? But after that, they're calm. And mostly, they sleep. But you can talk to them. Now, very rarely, you may encounter patients who are troublesome with 1 milligram of Xanax. So those patients, intraoperatively, I may give them another 0.5 or 1 milligram, and they are okay. It is a medication that you have to prescribe, and as a dentist, you are allowed to prescribe it for your patient, and it is very cheap. 1 tablet is about $1 US. Next. No, they don't have to be NPO. That's another good thing. They come, they eat, they do whatever, right? And of course, you have to tell them that they have to be accompanied, because they're going to be drowsy and tired at the end of the procedure. So this ends the lecture for today.